I'd like to request the next speaker for today. Management of residual refractive error. You have done a very good job. You have put a premium IOL, and then there's a refractive surprise. Dr. Love KOCHGAWAY, who is a senior ophthalmologist at Calcutta Trinetralaya, he'll be speaking on management of residual refractive error. Dr. Love, please.
Thank you, Dr. Satyajit, for the introduction and the opportunity. And the topic on which I would be speaking is management of residual refractive error after cataract surgery, and especially when we are using premium IOLs. So before we proceed, we should know the possible reasons for the refractive surprise, and some of the reasons which I have enumerated here is applanation tonometry before biometry. What we do at our center, that when the optometrist is doing workup and the child or the patient is having a cataract, we do the optical biometer first and then do the AT and then dilate. So that is one of the ways by which we can minimize errors. Dry eye, as we all know, is one of the potential and most common, I would say, the source of error. Poor fixation by patient during biometry, poor prior refractive procedure like classic PRK, and contact lens related corneal warpage. And for non-premium IOL category, silicone oil and posterior staphyloma are some sources of error. And one very important, though we sometimes don't give it that much of importance, is the typographical error, if it happens, or maybe clerical error, or by the doctor or the optometrist who is deciding the IOL. So setting up patient expectations is very important, because we should never overpromise. We should never tell the patient that it will guarantee spectacle freedom when we are doing premium IOLs. Always under promise, and what I generally say, that 90% of your distance and near may be possible without spectacles. Sometimes for 10% of your job you may need spectacles, so that dampens the unreasonable expectation by the patient, and when they get total spectacle freedom, they are delighted. So once it has happened, how do we identify the source of error? So in this, what we have to do is defer again glass appointment by 1 month after surgery, do a refraction again, dilated examination, recheck patient history, surgical records, formulas, IOL choice, repeat all the biometry, keratometry. Sometimes cystoid macular edema or some macular edema may be the cause of the refractive error, and if none of these are responsible, then assume that the error is due to effective lens position. So management can be either medical or surgical. In medical management, if the patient is satisfied, sometimes we are not satisfied, but the patient may be satisfied. So in those cases, just observe, don't tell anything. If the patient is unhappy but amenable to using spectacles after surgery, we can give them spectacles or contact lens if it is astigmatism or anisometropia, or if the patient is a previous contact lens user and not objecting to it. Surgical management can be either a LASIK or PRK, and these are the choice when the refractive error is less than 2 diopters. There is no corneal pathology, no photopic phenomena like glare, halos, and decreased contrast sensitivity. But when we are deciding about laser-based procedure, we should wait for at least 3 months after cataract surgery before offering that. Next will be IOL exchange, and probably I would say this is one of the common surgeries performed in refractive surprise, and if the refractive error is more than 2 diopters, we know the source of the error, then we are sure that IOL exchange may give a better results. If there is a visual phenomena with premium IOL and you have waited long enough and the patient is not happy with it, we can offer IOL exchange. Technically, it is easier in the first 3-4 months, after which the fibrosis sets in the bag, and that we have already discussed in premium IOL exchange may increase the glare, halos, and decrease contrast sensitivity. So if it is a trifocal lens and we are going for a IOL exchange with another trifocal lens, we have to sensitize the patient that it may not solve the problem fully. IOL rotation is another choice in which if it is indicated in wrong IOL axis placement, but in late IOL rotation due to fibrosis of the capsular bag, it is better not to advise. Post-op astigmatism is the reference point for calculation, not the pre-op value, and there are various online resources. One is astigmatismfix.com, and second is developed by Dr. N.S. Verma, who was one of our instructors, and they have developed a very accurate for online calculator for this. You can discuss with him after the session is over. And if it is a residual hyperopia, then piggyback IOL is one of the choice. And piggyback IOL, when we select, when we don't I know the IOL power that was implanted, fibrous bag makes IOL exchange risky. AC depth is optimal, maybe 2.8, 2.9 or more. And if it is a hyperopic surprise, then the calculation is rough calculation will be 1.5 into the manifest spherical equivalent. And if it is myopia, 1.3 into SC. And there are various online resources also available for piggyback IOL power calculation. So with this theoretical part, I will just give 4 examples in which I have faced very severe, some severe, some not so severe problems of IOL surprise. When I was in the first year of my practice, I operated a 19-year-old, and the source of error was typographical. That time in Shankar Netralaya, we used to manually enter the values in their calculator and take a printout. And the person who was doing did a wrong entry, and we ended up with a -9 refractive error at glass appointment. So luckily parents were cooperative, they didn't create much problem. Next day we did a IOL exchange, and she got a good vision and is a happy patient, still following up almost 20 years later. Second was again in early days of practice, post RK. That time the newer machines were not available, and even I was not that well trained. So I ended up again this time with +9 at glass appointment. And this patient gave me a hell of a time, and they were from, I still remember, they were from Jamshedpur, but I got a call from Times of India, Bangalore. And they said, doctor, there has been this problem. I think there is a negligence from your side. We are planning to print this. So we got into panic mode. I immediately called our chairman. Then Dr. Badrinath called me immediately. Doctor, what happened? Sir, first thing, doctor, you should never talk to anyone in the press. Sir, I told, sir, I have not spoken. I am just informing you what was told. And he pulled his strings, and actually we searched the phone number on the internet, and that was of Times of India, Bangalore. So he pulled his strings with top management of the Times of India, and we were able to overcome this crisis. This patient went to Shankar Netralaya, Chennai. They were offered piggyback IOL there, but eventually it lost to follow up. But we came to know that somewhere else they got a piggyback IOL done in this case, though IOL exchange would have been a better option. Third encounter is one of the senior surgeons in our center, and he did a trifocal lens and it ended up with 0.75 diopter surprise. 2 months, for 2 months he was bearing the son of the patient, because that he was stuck on one point, that I have paid a price of a premium IOL and I should not have 0.75, and he was giving hell to him. So finally 3 months later he roped me in and again 2-3 rounds of counseling I did. Then finally 4 months later, son was insisting, was posted for IOL exchange that day. That day again I called him and I told that eye is of your mother. So for your value of your money, and if you're 4 months later you are going for IOL exchange of a trifocal with a trifocal, which we saw that it may not have that good result. You may have to bear more consequences. Finally, at that point, he broke down and didn't insist for IOL exchange and went for other eye trifocal lens, and which was a 0 power, and then the patient was happy. So this is are some of the, and the last slide, this is the last slide. It is one of my own patient. She had come from US for surgery, and we gave, she opted for VVT lens, and we gave 0 power on the first eye. But 1 month, 2 months down the line, I came to know that she is not using spectacles for near, and almost 1.25 for near has to be used. She was not keen for near spectacle at all, so I aimed for minus 1.12, slight myopia in the other eye, but ended up with 0.75 with 0.5 cylinder. And now her unaided vision was 6.6 and 10 in the better eye, which was 0 power, and 6.12 part and N8 in the other eye. But she was happy that she is able to see near without spectacles, and we ended up with a happy patient, though it was a case of a refractive surprise. So these are some of the situations of how to deal with, and we can have a discussion about it. Thank you so much.